Good evening, everyone. Good morning in some parts of the world, and good night in others. Very happy to be here with you today. My name is Vernon Vincent, lap band clinical specialist in medical affairs with Reshape Life Sciences. Welcome to Reshape Life Sciences webinar, Why Lap Band Now? Thank you for honoring us with your time and interest today. Even with all the Zoom fatigue, over 100 of you have registered to attend and watch today. Thank you. We have attendees from all over the world, from 26 countries. What's going on here? Well, that's exactly the topic for today. Next slide. First, some quick housekeeping. All attendees are muted. Please use the chat function on the toolbar on the bottom right. Send us questions. As best we can at the end of today's session, we will answer those questions. Any questions we don't get to, I will get back to you personally by next week sometime. The complete recording is available of this event as soon as it's completed, so you are able to share it or watch it again at your leisure. Next slide. Today's webinar follows a long series now, nearly 2 years of webinars. Here's tiles from 6 of the 10 we've done, covering topics of mythbusters, evidence-based aftercare, information for new surgeons, fellows, expanding your practice even during COVID, thinking about the band as a procedure for outpatient, for instance. All of these are available. If you're interested, you can contact me or your local representative and we can get you the link. Next slide. Today's agenda is very simple. Briefly overview the lap band journey, what has happened to the lap band, and who is Reshape Life Sciences, and then quickly into the fall of the lap band with Professor Jean-Marc Chevalier from Paris. Then, is there a role for the gastric band in 2021? Mr. Summers from the UK. And finally, lap band as first choice. 23 years experience on 4,000 patients, Francesco Forbetta from Italy. Next slide. The lap band has been on quite a journey, exploding onto the scene as the first device for laparoscopic bariatric surgery in 1994. Grew in numbers rapidly and actually was the source of the first growth in the number of overall bariatric procedures in many, many years as it grew. The sleeve came along and other interests developed. A number of ownership changes in the company and changes in focus and attention, actually, that resulted in changing directions and losing focus on the lap band system. Just about 3 years ago next month, Reshape Life Sciences purchased the business and has been in a steady rebuilding mode of reconstituting a team of like-minded professionals from the CEO, Bart Bandy, on down to group that really believe in the opportunity that the lap band represents and have an unfinished business agenda among us. Reshape is an entirely different company now. Next slide. Having initially been focused in gastric pacing and a balloon, at the acquisition of the lap band, both of those changed so that the Reshape became the lap band company. And since then, in rebuilding the business, we've been building to become the bariatric surgery company. Recently acquired Obalon technology, and that will be discussed at some length in a future webinar. And we've expanded to include things like Reshape Care, or digital aftercare, and most recently Reshape Optimize. Again, we'll tell you more about that. Optimize is a nutrition supplement line to augment our bariatric procedures. Next slide. Significant investments have been made. Most recently, as a month ago, we started a national print and TV campaign. These are 2 of the actual ads. They're in a number of ads in the United States. As soon as we continue to get our feet under us and sort out international regulatory, we intend to expand this globally. Next slide. TV ads as well, and these are fantastic. Actual patients telling their testimonials, passionately explaining what they've done and why. We have short ones and long ones. It's 2 versions, in their own words, and another one that's called Lunch Talk, where prospective patients talk about what would you do and why. First time in over 10 years that there's been advertising for the lap band, and I'm very happy to tell you that it is working. We are seeing a significant number of calls to our call center. The interest is high, and we're able to transfer those to lap band practices across the United States. Those of you outside of the United States, that may be a surprise to you, as some have told you nobody does bands in the United States. Well, I'm here to tell you that that is not correct. We're growing and doing quite well. Thank you very much. Next slide. So my obligation and commitment, as always, and that of Reshape Life Sciences, to make this time worth your time and make it valuable. So let's get to it. If I could ask my faculty to turn on their cameras and microphones. Very pleased to have an expert faculty today from across Europe. We have Professor Jean-Marc Chevalier from Paris. We have from the United Kingdom, Mr. Shaw Summers, and from Italy, Dr. Francesco Forbetta. Interesting detail, they began their bariatric surgery experience in 1995 with the lap band system. It's our pleasure to have such an esteemed experience and congenial faculty for today's webinar. Next slide. Note that none of our presenters have any conflict of interest, and we'll go right to the first presenter. Jean-Marc, tell us what you have to say for us today. Everyone else, let's go.
Okay, thank you, Vernon. It's always a pleasure to share with you presentation, and I'm happy to co-chair it with Sho and Francesco. Next slide, please. I've been doing, we can do probably to the next slide. I put 3,500 bands over a period of more than 25 years. Show the next slide, please. It's my case mix slide, a period of more than 25 years in an academic center in Paris. And as you can say, I'm still putting bands. And when I'm asked why, I say because every week, many of my patients come back and they are very happy with their band. So go on. The bands must not be bands for the following reasons. Some of the long-term series led to inappropriate conclusions. There are data showing many progresses. We published selection criteria, and the long-term results of the different procedures are quite equal, and the band is safe. But the problem essentially is that follow-up and surveillance are mandatory. And for me, it is the main reason why many surgeons gave it up. Next slide, please. For example, this work from my friend Michel Suter showing that there were 33% late complications with 20% reoperation and 3% complications every year, with a total rate of 60% acceptable long-term results. For me, it's not a failure experience, but it requires selection criteria. Next slide, please. Another series from Switzerland by Ralph Peterli, old bands. 85% of the patients were followed, 30% had still their band in place, and the good to excellent results according to Barros were 15% of those who were in place. But these old series were in old bands. Next slide, please. The series of Jacques Himpens, for example, where patients operated from 94 to 97, half of them were followed, very questionable number of erosions, and the total of 48% that have still their band in place with 60% of satisfaction index. Next slide, please. And both these old series from Michel Suter and Jacques Himpens said the same thing about the limitations, because these series were studied on old bands, the first bands that were high pressure bands, essentially, and also the old perigastric technique. And we all know that we had much more complications with this perigastric technique, and that using after that the pars flaccida technique, the number of complications decrease tremendously. I will show it later on. Next slide, please. in our experience, we collected all the results 12 years after the perigastric technique from 97 to 99. And to sum up, we had correct decrease of BMI from 44 to 36, with success in 32% of the cases. But what was interesting is that 47% of the younger patients, less than 40 years old, had a success. And that's what led us to select the good candidates. Next slide. In the very important long-term series of Paul O'Brien from Australia, more than 3,000 patients have been followed with a follow-up of 81%, and many of them more than 10 years. The 15 years excess weight loss was 47%. And what's interesting is that he divided his experience in 3 different periods. The older ones were the perigastric, and then the pars flaccida, and then the last AP lap band. And the earlier high frequency of late adverse events has been reduced markedly. For example, the incidence of revision decreased from 40% to 6.4%, with a band explantation rate of 5%, which is also our experience. Next slide, please. And we published in 2007 selection criteria in Annals of Surgery in univariate and multivariate analysis from the most to the least powerful. The selection criteria was initial BMI under 50, patients accepting to change eating habits, restart a physical activity, operated in a team who does more than 2 bariatric procedures per week, and younger, age under 40. For example, next slide, please. In the BMI, you see very clearly that the group of patients with a BMI under 40 and under 50 had a better results than patients with a BMI above 50. Next slide. And we had also compared the 2 groups, our old historical data in blue and after selection criteria. We see that the BMI decreased much better in the selected group than in historical one. Next slide. If you look at the very long-term series after 12 years, you see that Paul O'Brien said that all current procedures achieve substantial long-term weight loss, and there is no difference for him in excess weight loss between Roux-en-Y 54, band 54.2. The BPD is a bit better. But he said that the band is safer than the Roux-en-Y, and long-term weight loss outcomes and need for revisional surgeries are not different. And Joachim Pence, in his thesis in 2016, showed that after 12 years, there is no big difference between the different procedures. With band, the weight loss results, although slightly inferior, appears to be sustained over time. Next slide, please. This is also for Paul O'Brien, more than 10 years. There is no big difference in excess weight loss. You must not pay attention to the OAGB because there were only 2 reports, and for the sleeve also. So for the Roux-en-Y, the weighted mean is 55, for the band it's 46. The big difference with the BPD-DS, which has better excess weight loss. Next slide, please. And this paper is interesting because it compared 76 patients having a sleeve to 76 band since 210, and the weight loss after 10 years was not so that different. For the sleeve, it was 22.2, and for the band, 21.2. So no difference. If you see the curve, next slide, please. Next, yes. In short and medium term, the superiority of the sleeve is clear, but at 10 years, the two procedures show a similar outcome. Next slide, please. And we must not forget that the results of the sleeve at long term are not that good. For example, after 10 years in the University of Vienna, the paper from Gerhard Prager showed that there is an increase in PPI treatment, and 60% had weight regain, with in 14% Barrett's metaplasia. Next slide. And we must not forget that safety is mandatory in young patients. In our academic centers, we received awful complications after sleeve, like this gastropleural fistula in 22 years old female, which required a total gastrectomy 18 months after. The second one was gastrobronchial fistula in a 24-year-old man that was cured in more than 250 days. And this gastrocutaneous fistula, and the third with a piliphlebitis that died 18 months after the sleeve. Next slide. And Franco Favretti collected 12 years results after bending. What's very interesting is that he had 100% follow-up from the beginning of the story. Next slide. And he showed that the curve was stable with a weight loss of 23.8 kilo at 10 years. Next slide. So what's important is to show what kind of improvements have been done, because these improvements led to improved outcomes. For example, when we convert from high pressure band to low pressure, and most important is the better attendance at aftercare. In the series of O'Brien, between the period of the 10 centimeter and the AP, the explantation rate decreased from 12% to 5%. Next slide. This aftercare is very important. The follow-up is mandatory and time-consuming. We know since a long time that the results will be directly dependent on the number of post-operative visits, and that the band adjustments must follow the green zone that had been described by John Dixon. Next slide. So that's why when I see a patient now, I tell him always, you have morbid obesity, we can help you by 3 different steps. The first step is medical treatment, diet, and psychological support. The second step is to help you changing your eating habits by a gastric restriction, which can be either a band or a sleeve. But the drawback of that is that if you don't have correct eating habits, the stomach may dilate and there is a risk of weight regain. And so the third step is to do a restriction of the stomach and of the bowel by a bypass, but then there will be vitamins mandatory. Next slide, the last one. The patient must know that there is no miracle operation, but that he needs 3 periods: a good preparation with medical, dietetical, and psychological assessment to choose the best operation adapted to his eating habits, then a good operation and a good surveillance, good follow-up. Any procedure requires to be followed A band has to be followed because of diet and inflation, but the sleeve has to be followed because of diet and endoscopy, because of the reflux risk. And the bypass must be followed because of the vitamin supplements. I thank you really for your attention, and we'll be ready to listen now.
Thank you so much, Jean-Marc. I gave you an impossible task of presenting 15, 20 years of data and literature in a few minutes, and you did a very fine job. We'll have some time to hear a similar presentation from a different perspective in a moment here. So we'll move on to the next presenter. Pleasure to introduce Mr. Shah Summers from the UK. Come on and we'll get you going here, Shah. Thank you for your time this evening. It's all yours, Shah.
Thank you, and good evening worldwide. It's a great pleasure to be presenting to you about the gastric band. And as Vern and Ted, we've all three experts started off doing bariatric surgery in 1995. And at that stage, I was an open surgeon mainly, and laparoscopic surgery really took the fore. So the question I was given is to answer really, is there a place for gastric banding in 2021 and 22, today's day and age? What does the evidence show, and what is my practice? So next slide, please. So the answer is yes, of course there's a place for gastric banding. And I think what we're struggling with is not, do gastric bands work? Clearly they do. In the appropriate setting, with the appropriate treatment, patients do well. What we're really struggling with is where we use the gastric band and where it sits in amongst the procedures that all help patients struggling with obesity. Next slide, please. So if we go to my bariatric experience, I am an upper GI and bariatric surgeon, and I've done at least 3,000 procedures. And to this day, I do lots of bypasses, sleeves, and probably 50% of my work is revision work. And I'm very strongly of the belief that revision surgery is not because of a failure of bariatric procedures, but as with any benign functional surgery, procedures will fatigue, or the patient fatigues working with it. And we need to accept that just like hip replacements, hernia repairs, sometimes they won't last the course and they will need to be changed to a different procedure, sometimes a stronger, more durable procedure. That is not because the first one failed, it's just the patient requires stronger treatment. Next slide, please. So if we look at the history of the band, Vern's kindly presaged that for me, but it's been around quite a while. Back in the 80s, the first ones were implanted open and the technique was established. But it really wasn't until 2001, when the FDA gave approval, that there was an explosion of popularity worldwide. And because it was the only laparoscopic bariatric procedure, it really took off because patients found this acceptable. They were not willing to accept an open bypass, which was the only alternative, or a BPD. A band seemed an acceptable alternative. And this is what us as surgeons have got to get our heads round. What we think is easy, straightforward, and acceptable surgery for a patient is not always what the patients will accept. A band as a concept and as a procedure is an office-based day case procedure. Patients will accept this. They won't always accept resective surgery, even though we may have the evidence that it's as safe as anything else. It's not as acceptable to the patients, and they're the ones we're looking after. And it wasn't really until the mid to late 2000s that the procedures such as sleeve and bypass started taking off as laparoscopic procedures. So the band really did establish itself. Next slide, please. Our problem really occurred when those initial results really belied the reasons why we promoted the band. So, we know there's all these reasons why a band is preferable to a resective procedure for those patients who do not need a fully resective stapled bariatric procedure. Next slide, please. So we have to contend with some of the bad press that came out early on, looking at the early results. And Jean-Marc has kindly already explained a lot of this. But when you see reports like this from such luminaries as Jacques Impens and Guy Bernard Cadier saying that, you know, 1 in 3 patients experience band erosion, clearly everyone takes fright and the band loses a lot of traction. Does this mean it doesn't work? Well, if you look at the left-hand graph, those bands that remained in worked well, right up to 15 years. So this is not a procedure that doesn't work. It's a procedure that has, in this series, a very high complication rate. Next slide, please. Why was that? Well, the band fell from grace because when it first came out, everyone thought they could do it. The band is not an easy procedure. You need to be an upper GI surgeon with experience around the hiatus to place it accurately and properly in every case. And every case is not identical. The mechanical complications, which were quite common in the early days, are really a feature of poor quality surgery, surgery that isn't accurately placing the bands, accurately fixating them, and paying attention to port placement. The other thing that became clear was that patient education early on, pre-op, with a management of their expectations from banding was essential for them to be firstly good at working with it, but also happy with the results. You also have to have an adequate aftercare infrastructure. And that's what we're really bad at as surgeons. We like to see patients have their surgery, see them in clinic once or twice, and then sayonara. That's not the case with bariatric surgery, especially not the case with gastric banding. You have a long-term relationship with your patients, in fact, lifelong. You may see them more frequently in the first 2 years to get their adjustment optimal and to get them to a stable nadir weight, but then the relationship will continue lifelong. The other problem is that there were the evolution of more effective alternatives, such as the sleeve and the bypass, but more effective in whom and why? Next slide, please. If we look at the IFSO Global Registry, a number of interesting facts come out. So of the 500,000 bariatric procedures that underwent between 2015 and 2018, you can see the gastric band took 4th place at around 20,000 procedures. But in the period 16 to 20, the 4 years, gastric bands were only half that. But hang on, that's COVID time. And if you look at the total procedures, it's roughly half of the procedures in the preceding period. So actually, gastric band is holding its own. People are still using them because they still work. The rise of the other bariatric procedures is not surprising because we have a world epidemic of obesity, and the majority of patients coming forward for bariatric surgery are those who are desperate. And for those, it's probably more appropriate that we do sleeves and bypasses because they are comorbid and have a high BMI. But what we're missing is all those people in the moderate obesity category, and we're talking BMI 30 with comorbidities or 35, who really don't necessarily need resective surgery, for whom a band may be perfectly adequate. Next slide, please. So that's not a repudiation of gastric banding just because other procedures are more popular. Again, Paul O'Brien's series shows that with good quality aftercare, long-term results are at least as good as resective surgery because patients tend to hold on to their weight loss, unlike sleeves and bypasses where after 5 or 10 years the weight goes on. I've been doing bypasses for 25 years now. All my original bypasses are starting to come back with weight regain. Now what do? Wouldn't it be better if we'd started with a band and explained to them that you may need more than one procedure in your lifetime to combat your obesity problem? Next slide, please. So here's a couple of series from some private clinics that work in the UK. One on the left from the Birmingham Healthier Weight Group followed 2,000 patients undergoing gastric banding over a 10-year period, and they find excellent results. The mean excess weight loss for broken down by BMI over and under 50 of around 40 to 50%. Similarly, in our group, we followed very closely a cohort of 300 patients over 24 months. And these are patients who'd chosen the band after good quality education, had their gastric band fitted by experts who do lots of bands, and then they were followed by a proper, fully fledged aftercare team for regular band adjustments, regular diet adjustments, and regular attitude adjustments. This leads in our hands to at 24 months and approximately 66% excess weight loss, and that's maintained in the longer term. We do have our mechanical issues. There were 5% band related complications with slippage, port tubing, and gastric band leak, but only one conversion to bypass due to intolerance. This is not a procedure that is a failure or not useful. These patients were really happy. Next slide, please. Another interesting article published recently by George Fielding's group is that you can tell how well someone's going to do with their band by their 1-year weight loss. And what does this mean? If you've got a great aftercare system and these patients are properly counselled and looked after in their first year, they will achieve significant weight loss in their first year, and they will build on that and maintain that in the longer term. That's a really good indicator that your aftercare system is vital. And it shows that certainly in his group, the total weight loss of over 20% can be maintained at 8 to 12 years. Again, what's not to like? New slide, next slide. So what's our recipe for gastric band success? Patient education, number one. The band is more or less a restricted procedure. There are some other mechanisms that help people lose weight, and when properly adjusted, patients do say they have satiety. They don't feel so hungry. Patients should actively choose the band because of how it works, not because of financial reasons or because they're frightened of anything else. The technique needs to be exacting and careful. You shouldn't be doing 15 bands in a day. It's just not right. Even though Vern might like that. There needs to be proper aftercare support services, correct brand adjustment protocols, and some alert and rescue systems in place so that if patients do experience trouble, they are dealt with and remedied early. And there needs to be long-term follow-up. Next slide, please. So where does it sit? We have a hierarchy of interventions for obesity. This is not a competition of my procedure is bigger than yours. This is what do we offer patients at various stages in their treatment for obesity. So the band sits very nicely between injections, balloons, and sleeves and the resective procedures. There is absolutely no reason why it shouldn't be offered to patients as long as you've got the correct aftercare system. Next slide, please. This has been borne out, and I'm hoping will actually come to fruition with the results of the largest randomized controlled trial of bariatric surgery in the world. There's over 1,800 patients been randomized to bypass, sleeve, or a band. The decline in gastric banding has led the two main investigators, Jim Byrne and Richard Wellborn, to write to the editor of Obesity Surgery saying, please don't throw the band out with the bathwater. There are too many people dissing the band, saying it doesn't work, look at all these revisions, without looking at the context at which they were used. So the gastric band should not be written off until there is any evidence to suggest that. And I'm afraid until to date, there is no evidence to suggest the band does not work or is not useful in the right patients. Next slide. And my final slide, yes, there is a place. Thank you.
Very nicely done, Shaw. Thank you very much. And just to address one comment, I'll flash one thing you said. Actually, our revival plan very much focuses on good programs doing good procedures and aftercare. We had thousands and thousands of surgeons doing bands. Not very many of them had good programs, so most of them not continuing. So our revival is to partner with programs like yours who do everything, not just the surgery. We actually don't want programs that put in one a fortnight, and we don't want programs that put in 15 a day and never see those patients. Both of those ends of the spectrum are not good for the patient and not good for us. I can't live long enough to do this again. We know better.
Yeah.
Very well put.
We should know better.
Study, yes, the BiBand sleeve study out of the UK is extremely interesting in that its structure and complexity, and it's a prospective randomized study. I'm not sure it'll ever be able to be repeated. Truly randomized patients walk in and don't know what they're getting and are able to come out with a procedure. And soon, next year or two, we anticipate that data being presented. And I'm very happy to see the recent bathwater publication. Great. Okay, well, thank you. We'll move on to our last presenter, and we'll come back for some general questions later. From Italy, I have Dr. Francesco Furbetta, Director of Surgery, General Bariatric at Leonardo Soligna Vincenzi Hospital. And Francesco, it's very nice to see you again. How are you, sir?
Hello. Thank you for having me. Welcome, everybody. I am happy to be here with you. So I am keen on gastric banding, and what I am going to present is my experience for on gastric banding. Next slide, please. I am a general surgeon, an endoscopist, and bariatric surgery is about 50% of my surgical experience. I performed more than 6,000 bariatric procedures and more than 4,000 lap bands. Next slide, please. Why lap band now? There are two messages that I have got on my long experience on bariatric and especially on bariatric gastric banding. First of all, it has stood the test of time, and it has spectacular advantages and evolution of its prerogatives, and we have long-term results. But the second message is that gastric banding grown from an operation to a part of care, and we focus on interdisciplinary team priority, new targets, and sequential treatment. New slide, please. Next. Gastric banding is a well-codified technique. This means that it is reproducible, evaluable, amendable, and we can treat contemporary hiatal hernia. Effective with long-term results. Long-term are the reason to perform a bariatric operation, because in the short term, everything is good enough. It's safe. It's really a very laparoscopic operation. Not only it's safe regarding the mortality, but there are no operative complications, and post-operative course is easy. And we have well-codified laparoscopic operation to solve late complications. It's adjustable. It's reversible. Next slide. On my personal experience, we have very good results after 20 years. And what's mandatory is the follow-up. Follow-up means interdisciplinary team to check up our patients. We have more than 70% of follow-up after 10 years and is almost 60% after 15 years. And the percentage of excess weight loss is more or about 60% after 20 years. These are very interesting long-term results. Next slide, please. Here we can see how important is follow-up rate to achieve the best result, but also to focus on the efficacy of the procedure. Because when we look at the other procedures where the follow-up is about 15%, we don't know what we need about the real efficacy of the procedure. If we don't have follow-up, we don't have the numbers to evaluate the results. Gastric banding requires an interdisciplinary team to achieve the best result. This is mandatory. Next slide. Safety. There is no, in my experience, we have no mortality, no major complication, easy post-operative course, no post-operative intensive care, no investigations. We have late complications, but non-life-threatening. Dilatation herniation about 6%, erosion 2.6%. But remember that we started 25 years ago when the technique was very different. And now we have a well codified laparoscopic endoscopic solution to complications. Again, next, please. Next. Advantages of its prerogatives. Adjustability. When the interdisciplinary team works, we can adjust our bending to achieve the best result, but the cons related to the technological power indicates to deflate the bending or to go on with a semi-liquid diet. And in this manner, you have a scheduled failure. Next slide, please. The other fantastic pros of gastric banding is reversibility. Reversibility is fantastic, aware of the incoming solution, aware of the future needs of the patients, aware of the surgical limits. Cons are that nowadays, to follow the endorsement by the technological power, we have to remove every band and follow the current surgical trend. Next slide, please. And in this field, reversibility, that is really the best quality, I think, of an adjustable tool become a guilty merit. And when we evaluate what happened to our patients, we say that several authors say that there are several reduced surgery to remove bending and to come back to the initial anatomic situation. I can say try to do it after sleeve gastrectomy. Obviously, when you perform a reduced surgery in a not reversible procedure, you go to move with redo only to solve failures and complications, never to reestablish anatomy, never to modify a not satisfied patients. And I think that this merit, gastric banding, can't be reversed into something negative. Next slide, please. What do I mean with technological power? That nowadays technology is obviously fantastic, very useful, but nowadays maybe endorse operations and surgeons and propose new targets, and in some case overcome ineptitude, and there is some kind of business power naturally. But we have some duty regarding medical science setting. We have to do what's rational, and only expertise can dictate type of operation. And we have to look at long-term results, at safety and side effects, and ethics problem. Next slide, please. This is an example of what I mean with technological power. I had to remove this band. You can see it's inside out, and this wasn't. This was a band that doesn't work, but this is a bariatric surgeons that put this band inside, and on the other side we propose an endoscopic plication. When many surgeons don't believe that plication is useful, but it becomes useful if you do it by an endoscopic approach. There is something funny going on in this definition. Next slide, please. What are the new perspectives that I got during my experience? Nowadays, for me, adjustability is the way for the best result. I invite all my patients, when they are on the right way, to perform scheduled deflations to obtain the real best result. Remove it when it is no more necessary, when we have a re-educated, no more obese patients. This is my target, my new target, and I can get it through gastric banding. Next slide, please. The rationale of my gastric banding performances are that we are going to operate adolescent, and we know that 25% of them will never be obese in the adulthood, and we know that the BMI medium is about 40.41% on IFSO register. We don't have to operate only super obese patients. And we know that 90% of metabolic diseases improve only by weight loss. And we know that we have to use the less invasive, more effective procedure, and not to perform an operation, but to offer a strategy to cure the patients, and not to perform an operation. Next slide, please. At the end, gastric banding stood the test of time and offers a path of care. Gastric banding was and is a safety belt for me and my patients. I can move in this difficult field only because I have something that let me know that I am helping the health of the patients and not only performing an operation. I can select to the gastric banding the best procedure for unsuccessful treated patients with gastric banding. I can avoid over treatments, and in my professional life, gastric banding will be I devised this acronym It stand for Interdisciplinary Group for Obesity Treatment. But I got as the strength of something that you have got year after year, and this IT platform will be working to aggregate bending believers and offer an easy support to our patients. Thank you for having me. Bye-bye.
Thank you very much, Francesco. Very nice. Bon. Have the rest of the faculty join us back together now. So as we have them join us, go to the next slide and one after that then. Really appreciate your perspective on how things have matured in Italy, Francesco, and how you've grown your program around more adjustability and more selection. A common theme for all three presenters was patient selection may be as important as the aftercare. Surgeons would love a litmus test, a strip you put on the patient's forehead and it turns green for a band and red for a bypass. It's not available, and you have to use your best clinical judgment. Some patients absolutely will have nothing else and won't have a more aggressive procedure initially. What do you think about that approach? Is it reasonable to give a patient what they want to start with, and someday they may or may not need something else? Professor Chevalier, what do you think?
Well, if I correctly understood, it looks like what I say to the patients. I tell them, well, we can help you with diet, we can help you by restricting your stomach, or we can help you by restricting your stomach and your bowel. So it's 3 different steps. So there are many patients who are very compliant and that can lose weight with a band, that we see, because they understand how to eat with a band, small pieces of food, and it works very well. But some others, they don't understand, so they eat too much and they dilate the stomach. We've seen that with the band. We see now that with the sleeve, it's the same. It's always the stomach that can dilate. So it's a question of compliance. And as everybody told today, it's necessary to explain the patient before choosing this procedure, of course.
Very good, thank you. And Mr. Summers, what would you say?
Yeah, I think gastric banding is an option for those patients who we currently see. But if I may, my biggest bugbear is the fact that we see a tiny fraction of all the people that really need help with obesity. So why don't these people come and see us who offer bariatric treatments? They've heard it's safe. Well, they don't come not because they haven't read the data or they haven't understood the evidence. They come because they're frightened. They're frightened of a sleeve or a bypass or of the complications. And they've heard all these stories that banding doesn't work, which is false. It's not true. So I think what we have to do is to start to promote gastric banding and allow patients to choose. So I think for many thousands of patients for whom obesity is becoming a real issue, lower BMI, perhaps BMI 30 to 40, who don't have comorbidities, who are young and compliant and who want to change, a band is a good option. It's a good place to start. And I think this idea that you give them their best shot first, give them a bypass, is quite mistaken.
Okay, great. We do have a very good question in from the audience, and I just want to once again, attendees today from Italy, France, UK, Iceland, Turkey, Philippines, Spain, Hong Kong, Egypt, Switzerland, Argentina, Malaysia, Saudi Arabia, the Netherlands, Portugal, Russia, Canada, UAE, New Zealand, Slovenia, and Belgium. We have quite the audience interested today, and one of them from nearby me, past president of ASMBS, past president of ISSO, Dr. Kelvin Higa, asks a very good question today. basically said the following. What about diabetes mellitus? Would most patients with DM be better served with a sleeve gastrectomy, a gastric bypass, or an OAGB, even with weight loss the same? Who would like to challenge that question? Go for it.
So again, it depends on what the patient wants and expects and their age. And I think, you know, the data has shown that diabetes can go into remission with a band. And what does the patient want to achieve? So I don't think it's a lesser procedure overall. It's clearly not as effective in its early stages, a band compared to a bypass. But 10 years down the line, if you're doing this to a 25, 30-year-old with type 2 diabetes and you do them a bypass, what are you going to do when they're 45 and their bypass is dilated and doesn't work anymore? You're stuck. We hope there'll be drugs, but there's no guarantee of that. So I don't think it's a poor choice, and I don't think there's a mechanistic model that you can apply to every patient just to treat their medical condition. I think it's a discussion and each patient has to understand what's relevant for them.
Excellent, excellent. Francesco, would you like to comment?
I think that when you have an obese patient, you have to see the characteristic of the patients, the onset of the time when the diabetes onset, and the type of cure is going on. In any case, if you have an obese patient, you can see and you can get a good result with the gastric banding. If you have almost not obese patients, diabetic, you must perform a more effective metabolic operation, because you know that you can't modify with only the weight loss is diabetes. So in obese, very obese patients, you can start with the gastric banding and then turn on a gastric bypass if you fails. But if you have not real obese patients, diabetic patients, it's better go straight with a more metabolic procedure.
Excellent. If I may add, from my perspective, in the 5 corporate life that I've lived with the lap band, all the different approaches and styles of managing this business, there were certainly times when the message was a band in every pot. Everybody should have a lap band, and it's as good for everyone as anything else. And the data simply doesn't support that. The reality we know today, as I mentioned in the beginning, we know how it was done previously, promoting the band too aggressively and without any thought for these learned lessons. Bands as a staged opportunity, brilliant. Give the patient the awareness of what they can expect and the opportunity to make that choice. But to have it be the only choice may not be appropriate. And surgeon choice and patient preference together has to always be the decision. We are not here to tell you today that the band is for everyone. And each of you know, if you could pick the ideal band patient, it'd be a wonderful, wonderful situation. With a good follow-up program, for my money, the biggest variable, and I'll ask each of you to agree yes or no, the biggest variable isn't pre-op consideration, isn't what is their condition, isn't the procedure, it's the follow-up intensity, the length of follow-up, the education, and the commitment to coming back to follow-up that ultimately matters the most. Jean-Marc, do you agree, yes or no?
Yes, well, eating habits are very important. I think that, for example, sweet eaters are not a good indications for gastric restriction alone, either band or sleeve. And I tell them, if you are a sweet eater, you'd better have a bypass.
Okay, and Mr. Summers.
That's really preparation, and the dietetical assessment is very important to decide.
Thank you.
So for my money, yes or no, yes. for every bariatric procedure, aftercare and support are vital, but for bands especially.
Yeah, I'd like to add something. In oncological surgery, we need an interdisciplinary team, and it is impossible to treat nowadays an oncological patient just only with a surgery, and nobody today will perform an hosted operation in case of breast cancer because you don't have an oncological team. So if you don't have a team to select, to follow, and to improve the result of an operation, maybe it's better if you don't perform an operation. And when we see experience without follow-up, we can't express any consideration because we don't have something to speak about. First of all, you have to pose the better solution to the needs of the patients, and it's interdisciplinary team. Then you can have an operation that can work inside this team. Otherwise, we are speaking about nothing, about the result of an operation, but not the result for the patient.
Well put. I think we're all in very good agreement. Unfortunately, we have got more to talk about than the time allows. There are some great questions that we'll have to leave hanging. I'll just state them now, and I'll be back to the faculty for their comments, and I will be answering these individually. Have you had any experience using adjuvant therapy such as semaglutide in the treatment of your band patients, the new 2.4 dose? How about lower BMI patients with that? Do you think that band patients are essentially the same target population as our endoscopic treatments, endoluminal or balloons, or is it a different category, or is there overlap there? And with that, I think we do have to respect everybody's time and say thank you literally to the world for joining us today. For those here in the United States, it's the day before Thanksgiving. Many of us have birds to stuff and side dishes to prepare and a few large meals. We didn't really have the opportunity. We were hoping to show the commercial, one of our slides, this last slide here. It just doesn't play well on this format. It glitches and jumps around. If you're interested in seeing the commercials, we can show that to you individually. Gentlemen, it's been a real pleasure. I thank you for all the time in preparing for this, quite a lot of back and forth and slide prep and practice, and your patience with me. I sincerely appreciate it. And the audience that you drew from around the world. We had Malphobe on the line, we had Kelvin Higa, we had the world, some serious people represented here who are interested in what you had to say. I appreciate you very much for that. So with that, I'll say thank you, and to the world, happy Thanksgiving.
Happy Thanksgiving. Bye, Kelvin. Bye, Mel.
Bye, everyone. Thank you, everyone, for joining us.
Bye,
very much.
Bye-bye.